If you just go to the NCH side, go to videos, it should be.
All right. Excellent.
And I'm gonna move this chair out of the way too. So that way, or at least I'll move my seat out of the way so it's not obstructing.
Yeah, I don't want to have mine. I don't need to have this on. Yeah, let me know it's working. That's nice. I used to have one of those. Like when I moved to the bigger one.
So I got, this is a newer one. I got this. I forget the bag.
I know. They're so light. Mine got really beat up though. You don't have it in a special case either.
Yeah, I do. I have a very
Wait a minute. Are you wearing a case? Yeah.
I have a little thin case on it, and it's great. I do need to go to the Apple store because a few of the keys are running off, so I need to just get the keys. When I checked this one, there's something.
I'm probably one of them.
So today we're going to live stream this.
I didn't have this.
Have it on the website.
Make sure that the audience are joining. Okay.
Watch it. We're going to try.
Because I can
Yeah, I think we want to know what it is. And you have it aimed at the speaker. Yeah.
it has the podium and
And oh, you do see the screen. Good. Very good.
And not that they I'm a little nervous about so I'd like to get through the presentation.
So I think he's presenting. The second briefing, we start again.
Yes.
Yeah.
They won't think, well, there's a lot of
I have trouble getting in.
yeah, but arbitration.
CBC. I just.
I just have this password.
You know, that's true. The baseball guy.
Yeah,
I was like, I looked online. How much more you can do when you have that set? So I miss it.
Actually, I have to take a 9 o'clock.
I'm impressed.
So it's like, I'll go to Russell.
It's actually
There's
clear.
like only one entrance that they'll let you in if you're
The
not.
road. Which doesn't surprise me. This is the Congress here.
Better like.
Yeah, better
It's
like-
crazy. It really is.
I might end up putting this actually on a chair because I think whenever the table moves.
Uh-huh.
I thought there was a title slide for the whole.
There is. But we didn't.
Okay, so just. Yeah.
So everything's good case.
As always, the issue is how long to wait for people to trickle in.
It's just because the lines.
Was it?
Yeah. Did you just?
There's no line for me. Yeah, depends which door you use.
And they all sound like, especially during this time of year, it's
Sean's here.
Exactly.
We'll give people 5 minutes. Yes.
well, yes, you go to the.
I'm not sure.
Ready? Good morning, everyone. I know the security line is always a problem, so I expect that people will continue to come, but we're going to get going. My name is John Rother. I'm the president and CEO of the National Coalition on Healthcare. And today, we hope to familiarize you with a new way of dealing with out-of-control prescription drug prices. And I'm not going to belabor the problem. I think you're all familiar with it. But what's interesting is I think there is a way to deal with this that is not government arbitrarily setting prices in management. So we'll hear today about how it could work, how it works in other industries, and how it works in other countries. We have an all-star lineup to walk us through all this, and without further ado, I'm going to turn to my good friend and colleague, Glenn Nichols. Glenn is a professor of health policy at George Mason, and he's going to kick off with a kind of a broad overview. And then after Glenn, we'll go to Richard Frank, who will drill down on how arbitration could work for pharmaceuticals. Following Richard, we have Lee Purvis from AARP, who will describe how the system in Germany works, which relies on arbitration. naysayer, Joe Antos from AEI is going to give us some critical perspectives. With that, Lynn.
Well, thanks, John. It's a pleasure to be here. It's a topic that's become near and dear to my heart, and so we'll try to get out of the way so the true all-stars can get up here as soon as possible. I think it's fair to say and to begin acknowledging that America has conflicting objectives here. We definitely want innovation. We want new products. We want them to come to market and benefit patients. And we also want them to be affordable. And those two things turn out to be in natural conflict with each other. And when you think about it, we encourage innovation by granting patents and exclusivities, and basically granting monopolies. Some would say temporary, some would say it's pretty long. We depend upon competition to come and drive prices down so that eventually everybody can benefit from the innovation that has occurred. If you look at the way the small molecule market has worked over time, in particular after Hatch-Waxman passed, and some people on this stage and some people in this room had something to do with that, Hatch-Waxman is typically touted as one of the success stories of bipartisan health policy. First of all, you had Hatch and Waxman. It's pretty hard to get people farther apart on any kind of scale you want to draw. Second, what that law did was it extended exclusivity for 5 years for small molecules, and it gave a very concrete pathway to the marketplace for generics. So it very much streamlined and accelerated the path through FDA approval of small molecule competitors. And I'm sure all of you now know we're basically at 85, almost 90% use of generics where it's possible to substitute. So that was a great success. On the biologics, but we did get a later start, and the ACA, I'm sure you know, included not 5 years, but 12 years exclusivity for biologics. And the idea there, which was probably directionally correct, is that because it takes longer to get a biologic through all the development and trials, the effective patent life of a biologic is shorter than the effective patent life of an average small molecule drug. So the idea was, let's give them longer exclusivity. You can argue about 7, 12, 5, but it's got to be probably longer than 5 to be reasonable. So that's fine. The problem is, of course, cost. The problem is the price that comes out. And I think it's fair to say, when you look around the country, what we have done as a policy matter, because we have this American, I would say, reflexive rejection of price controls. We have essentially told our Medicare program in particular, when thinking about whether to cover a drug. Now, there's a term for that in nuclear war, and it's called unilateral disarmament. There's a term for that in economics. Space of the drug manufacturers. If you develop a drug targeted for the Medicare population, as Richard will show you, a lot of the most expensive ones are indeed that. There's no market but the Medicare market, and if there's no market but the Medicare market, we basically give them a blank check. And so what we know is we pay more than everybody else in the world. I'm not sure this is right enough, but the U.S. is the highest one you can guess. That's what it works every time. And this is post-discount. This is from the paper, which I highly recommend you take a look at. It comes from ASPE's sort of backup memo for the International Price Index idea, which I would observe is worth trying, Lord knows, right? It's worth a shot. At a minimum, it's worth exploring the implications of it and thinking about what it means. And I'll just say this is historic as a proposal because it's the first time in my lifetime, and I'm sure Joe is upset about this, there's a Republican administration that has proposed tying U.S. prices to foreign prices. And what this little issue is that on average, we pay 1.8 times what other countries pay for the exact same drug, and that's where they got their 80% overpayment and where they got their target for what they're going to say. What you see here is a graph comparing per capita pharma spending by country. And what's sort of interesting, some of you may have read Austin Frack a few months ago about what happened in 1980. Well, it didn't happen in 1980 in drugs, but it happened around 2000 we were spending about the same as everybody else, and then kaboom, right? So what the hell? It definitely changed lately. And then I would say when you look at Part B and Part D, what's kind of interesting is that Part D, which of course has the private PBMs doing their duty, we're only growing at about 3.2% on average per year, whereas Part B, you're looking at 7% per year between 2006 and 2011. Those were the early years of the program. But since 2000, reason why the sense of urgency is growing about Part B. Now, there are people in the world who say, yeah, but you know, if you look on average and sort of by class of drug spending growth wasn't that great. In fact, it's been coming down. Essentially, it's been coming down since the peak from Sovaldi in 2014-15. But if you look at the categories, I'm not sure you can see the colors. It's still true that branded price is worth $12 billion in news. So they're increasing the price of branded drugs after launch. What's saving us lately is the expiration of exclusivity. So it is indeed a very serious question about how to think about the length of the monopoly we granted. If it wasn't for what is come off patent and off exclusivity protection, we'd be in big trouble. So finally, I'll just say in closing, as I set up what in detail on arbitration, there's lots of Medicare negotiation. And a lot of people, including myself, are thinking about how one might structure it. There are a lot of issues involved. First, how the hell can Medicare do it? Second, which drugs would you do it for? How would you think about the process, et cetera? One device one might use is a concept called reference pricing. The International Price Index proposal from the administration is a reference price proposal, not unlike, in fact, exactly like what some of the health plans, in fact, in California, Blue Shield of California with CalPERS, said we're only going to pay this much for knee replacement, and if you want to go to a hospital that charges more, you're free to do that, but we're not going to pay for that. And what they discovered was, A, patients will direct themselves to cheaper hospitals, and B, the high-priced hospitals actually lower the price. So this notion of a reference price can be effective. The IPI, the European index, as the reference price. And what's kind of interesting about it is, like I said, tying it to what other countries have negotiated, where they're not stupidly tying their hands in negotiation. But they are, we would be under the Trump administration proposal, tying it by algebra to the European average. I don't know for sure, but I would suggest, and game theory would certainly predict, the manufacturers might figure that out. And they might adjust the way the European prices sort of work over time. So I'm just saying that ain't perfect, but it might be worth. And that's what Richard's going to talk about. But before we get there, I do think it's important to dispel one fairly standard canard or myth, and that is that any kind of government negotiation and price is somehow price fixing. Okay, this is not price fixing. Let me give you a concrete example. It's a nuclear submarine. Okay, there are exactly 2 manufacturers of nuclear submarines. There's exactly 1 buyer who is allowed to buy from them and to whom they're allowed to sell. And I don't know if you pay a lot of attention to this, but they're kind of worried about innovation. They kind of know that they have to maintain technological superiority or we're in big trouble. Okay, and so what they use is what they call fixed price incentive, which is essentially a target price. Then there's upside and downside risk based upon the actual performance of the submarine. Nobody calls this price fixing. Yeah, what is labeled what we're talking about when we talk about negotiation. And I would say we should just dispense with that. And so we will, and I'll get out of here. All right.
I have really bad small motor skills. Social skills aren't so good either. Negotiation using finding arbitration, and it's going to focus on Part D of Medicare. And let me start off with some facts that sort of are meant to augment sort of what Len just gave you. The first is Part D spends about $100 billion a year on, well, in the recent year, on prescription drugs. And in the 10 years ending in 2015, prices had gone up for brand name drugs, which is the point that Len was making, by about 269%. This is at a time when generic drugs are actually falling by, probably about 75% over that period of time. And Part D is projected to grow at about 4.6% a year over the next 10 years. But second half of that period, it's going to accelerate to something well above that. So I think that kind of sets the context. What is of particular concern is the reinsurance piece of Part D. And that's because it is, and I'm going to demonstrate this to you in a second, it is the thing that is actually driving up spending in Part D. And if you recall, what's interesting and unusual about the reinsurance section is that when a beneficiary hits out-of-pocket costs of around $5,000, suddenly the risk sharing changes dramatically. And that means that patients pay 5% out-of-pocket. Prescription drug plans are responsible for 15%, and the rest, 80%, is picked up by the taxpayers. And that is hold in your head as I kind of go through here. The other thing to recognize about the reinsurance segment of Part D is that spending is highly concentrated in a few drugs. And so drugs account for about 35% of the spending in that segment. And so there are a few high-cost drugs that are really doing a lot of the work in terms of driving up spending. So here is the evidence showing you that the reinsurance section is what's driving up spending. So in 2007, about a quarter of the total Part D spend was accounted for by the reinsurance segment. Today, it's a little over 56%, showing you that it has taken up an increasing share, which means that it's growing way faster than the rest of Part D. And that's really the thing that's driving up the spending. Now, lying behind the reinsurance spending increases are some unusual market circumstances. And that is that within the drugs that are most commonly used in the reinsurance segment, what you have is a lot of drugs that are unique, have neither therapeutic competitors nor generic competitors. And as I mentioned a moment ago, the insurance is nearly complete. And it turns out that when you combine essentially monopolies with almost complete insurance, you're essentially putting the patent system on steroids. And when you do that, you give a lot of pricing power to the company. And MedPAC estimates that about 96% of the run-up in price increases. Now, prescription drug plans for those types of drugs have very little bargaining power, especially if they offer real important clinical benefits. they have virtually nothing they can do. And what little incentive they do have, which is at 15%, is commonly offset through rebates that are really designed to neutralize those incentives. And so there's very little in the way of checks on price increases in that section of the Medicare benefit. So then the question is, why negotiation? Why not reference price or something else? Well, as I said, this particular set of circumstances that are most commonly found in the reinsurance part of Part D, limited to a relatively modest number of drugs, where the pricing power is extreme. And so the question is, what's the best way to attack this problem? Well, PDPs generally do a pretty good job at negotiating prices for the bulk of situations where there's either generic or there are a lot of fairly close therapeutic competitors. But for these circumstances, in the reinsurance section, the Part D plans have virtually no bargaining power for high-cost drugs with few substitutes. And so what we've done, one question is, by essentially removing that and allowing bargaining power to be concentrated on the purchasing side, can we create a counterbalance to the monopoly pricing with few substitutes and complete insurance? So that's sort of the case for why you might want to consider negotiation. Now, why binding arbitration? Well, in negotiation, what you'd like out of the system is you'd like a system where people have an incentive to stay at the bargaining table, and two, where in a sense there are rewards or there are encouragements for the negotiations to end in a sort of voluntary handshake between the parties that agrees on the price. And value statement, which is that you want to a system put in place that encourages private settlements. Now, binding arbitration is used in a variety of places. Public unions that bargain with governments where they're not permitted to strike, like fire and police, are in a situation where you have really asymmetric bargaining power absent some kind of system that brings them together. Binding arbitration is one way that that's accomplished, and it's been used by a variety of states around the country. Major League Baseball, which has been prominently proposed there, makes use of this fairly successfully. And just to sort of illustrate the point about encouraging settlement, 80% of arbitration cases are settled privately with a handshake between them and the team. Germany, as we'll hear about in a few minutes, uses it to determine the prices of some drugs. And what it does, in the spirit of what the point Glenn was making at the end, is it introduces a private, independent party to help settle where the prices are going to land. And therefore, it's not price controls in the sense of government imposing things through administered prices. So let me walk you through some of the mechanics now. Well, the first step is, as you might guess, is to you'd have to repeal the non-interference clause in Part D to allow for negotiation. But binding arbitration is administratively complex and somewhat costly. And so you need to limit the number of drugs that are up for negotiation to a relatively modest number. And so because of that, step two is you need to set criteria for which drugs are going to be up for negotiation. From what I just told you, two of my favorite candidates are high-cost drugs that are overrepresented in the reinsurance section where there's no competition, or little or no competition. But there are other criteria you could think of. Third step is allow the industry and HHS a specified time period to negotiate. And at the end of that period, if a negotiated settlement hasn't been reached, then you submit it to binding arbitration. And there are two forms of binding arbitration. There's final offer arbitration, where the arbitrator can only pick, doesn't have a choice of what price, HHS or bid price by the manufacturer, or in some cases they can ask for a third outside expert opinion, as some states do in labor negotiations. But the point is that the discretion that the arbitrator has is strictly limited. The other type of arbitration is called conventional arbitration. Basically, the arbitrator can pick any price that they think is reasonable or fair. Now, the fifth step here, it would be you need to select an arbitrator or a panel of arbitrators. And typically in labor negotiations, in like the Apple tax liability case, that was done in consultation with the American Arbitration Association, and the parties that are subject to the negotiation have some input into the process and can, in some cases, veto up to a certain point. Now, a scoring consideration, CBO matters a lot and prior score matters a lot. You need to think a little bit about whether you want things to be completely unconstrained. In pure arbitration systems, there's no constraint on the bargaining space. Here, you might want to put in some other assurances on both sides. So, for example, you don't want prices to go so low that companies will no longer want to invest in the area. And on the other hand, you want prices, you don't want prices to be so high that no money will be saved. So somehow you might find a way to set parameters on bargaining space, and you might do that ahead of time. In final offer arbitration, the arbitrator would be giving final bids from, say, HHS and the manufacturer, and would have to occasionally you might want to give them the discretion to pick an independent third opinion. And each of the bids would be accompanied by data backing justifying the position along with explanation. And then in step 8, in final offer arbitration, the arbitrator would be required to choose one of the two bids, and if they used a third opinion, that opinion typically could only be picked if it was in between the other two bids. And so that's the way it's typically done, for example, in union negotiations. Now, in conventional arbitration, in contrast, the arbitrator can pick any price they think is fair. And it turns out that has a variety of properties that are not that desirable. In final arbitration, there is typically final offer arbitration leads to more settlements. And that's been true on the union side and in royalty agreements. So just summing up, negotiation provides a counterbalance to monopoly supply. Binding arbitration encourages parties to stay at the table and reach negotiated agreements. Because arbitration is complicated, it can only focus on a modest number of drugs. In Medicare, a small number of drugs generates a lot of the cost, and therefore that suggests that there is a workable process here that could actually yield savings. And then as the market evolves and more competitors come in, then you return prices to the usual PDP market dynamic. I just want to close by showing you some numbers from the Office of the Inspector General at HHS. Yeah, so a couple of years ago, that 10 drugs account. So a third of 56% is a lot of money. Thank you.
So thank you for having me here today. Again, my name is Lee Purvis. I'm with AARP's Public Policy Institute, and I am responsible for handling prescription drug policy. So I have been given the extremely easy task of walking you through Germany's healthcare system in 10 minutes. So I am notoriously pithy, but I'm not sure I'm quite that pithy, but I'm gonna do the best I can. So first of all, what does the healthcare system look like? It is kind of unique in the EU in the sense that coverage is provided by, there's not single coverage. It's private, a lot of different plans. You can get coverage in two different ways. One is through something known as a sickness fund. That is where the vast majority of where people get coverage. And you also have the option of using a fully private plan. There is one entity known as the Federal Joint Commission. One thing worth noting is the German market, even though there are some similarities in the sense of having a multitude of private plans or separate health plans, they are much more regulated. And part of that is this committee. So this is a non-governmental body. It represents payers, private payers, and then patients. And it really has the authority to make coverage determinations. So this group makes decisions about what is going to be covered. And they really try to emphasize evidence. They want to assess what is being covered, and they want to make sure that it's something that works well for the people that are going to be using it. So prescription drugs, there are actually a lot of similarities as well in the sense to the US in the sense that they are very invested in making sure that people have choice, and they want to make sure that drugs are available. In the sense that until recently, drug manufacturers were free to set prices pretty much anywhere. They came on the market and they knew that they were going to be reimbursed for whatever price that they set. However, around 2010 or prior to 2010, the German policymakers were really alarmed by the prices and spending trends, again, similar to what we're seeing here. And they wanted to help bring down or at least slow down price growth and spending, while at the same time making sure that innovation continued and again, that patients continue to have access to the drugs that they need. So in response to that, in 2010, they passed a piece of legislation known as AMNOG. And what was interesting about that and the centerpiece of that is that they really heavily relied on comparative effectiveness research. So this process is incredibly complicated, again, trying to keep it high level. So at first, the drug needs to obviously be proven safe and effective. At that point, the manufacturer is free to enter the market at the price of its choosing for 12 months. So that's an incentive for manufacturers really to continue in that market in the sense that they have a full year at the price that they choose. Within that time, the Federal Joint Committee asks a non-governmental body known as ICBIG to take a look at the drug, take a look at how it compares to existing products. ICBIG evaluates that product within the year and compares it to the existing standard of treatment or comparable drugs. What's also interesting about this is the information that they use comes from the drug makers themselves, which I've always thought was very fascinating. They're the ones who provide the relevant data that are used in the evaluation, and there are actually penalties if they don't provide all of the data that's available. Within the time that ICBIG makes its decision, they submit to the Federal Joint Committee, and then they issue a decision in terms of whether they agree with the findings from ICBIG. Again, going back to the fact that Germans really are interested in making sure that there are incentives or appropriate incentives within the market. They do have some exceptions to the process. One is for orphan drugs. They submit a dossier of information like other drugs, but they already are automatically assumed to have an added benefit. There's also a little tweak in there that tries to prevent gaming of the system in the sense that once sales reach a certain point, the manufacturer then has to go back and submit a full dossier. So no orphan drugs that come on the market and just kind of results in a massive amount of spending. Vaccines, how other countries are pricing those products, and generics and drugs that are only used in the hospital are also exempted. So what do these ratings look like? First of all, patient perspectives, things that are interested patients are a part of this process. They're looking for improvements in health status. Is the disease duration shortened? Is there less side effects? Is there an improvement in quality of life? So once all of those things have been taken into account, as well as the research, you have a benefit rating. It goes from 1 to 5. You can either have a major added benefit all the way down to you don't have an added benefit compared to current therapies. They also take a look at the quality of the information, and you get a ranking of that as well. And the combination of all of that information is what ultimately is used by ICFIG to make a decision about the added benefit of the drug. So after ICFIG provides its recommendation, the Federal Joint Committee decides whether they accept it. If the rating is between 1 and 3, meaning there's some level of added benefit, can then begin negotiating with the insurers in terms of trying to negotiate a price. The added benefit level is what is used as the basis of the negotiation, and the fact that they're negotiating at the high level in terms of the price ensures that all payers in the country get that price. If the new rating is no added benefit, low added benefit, the payers only reimburse at prices that are comparable to existing products. And then, as we've heard previously, if no agreement can be reached, that's when arbitration comes into play. So arbitration is a five-member board. One is an impartial chairman. There are 2 other impartial board members, and then there are 2 representatives that are brought forth by the payers and by the drug company who's involved in the negotiation. The members of the panel are appointed for 4 years, and the decision is by simple vote. The decision is binding. They can go back and revisit it after 12 months, but you will have 1 year. And also what's interesting is if there are pushes back, whether it be legal or some other form, that price remains. So it's not going to stop access while those types of negotiations and questioning go on. Drug companies do have some options. The first one is don't have it assessed. If they don't, it can be reference priced and still go on the market. But it will be priced in comparison to generic alternatives as well. So obviously you're going to have a lower price in a group that includes generics. You can also choose not to offer the drug at all. So in terms of how it has worked so far, I think in the sense that what they were trying to do is pay more for drugs that have an added benefit and pay less for drugs that don't. That has been happening. In terms of the arbitration effects, what has typically happened is that the prices that have ultimately been significantly lower than where manufacturers had hoped to be, I think the average around 20% lower. In terms of savings, it's been billions of dollars. And those estimates typically have not included the savings from money that was not spent on drugs that don't have any added benefit. I think the other thing that's important to note is this is not stifled access. There are still hundreds of drugs that are being assessed in Germany. And actually, there have been relatively few drugs that have been pulled by the market, and that typically has been after they've received a relatively poor assessment, or when the price has been set lower than what they anticipated. So in terms of takeaways from this, I think the fact that Germany is relatively comparable to US in the sense that there are a lot of plans competing for business. And they also have a very strong emphasis on making sure that people maintain access to prescription drugs. And they also had very high prescription drug spending trends. This is certainly a country that's worth taking a look at. The system that they have structured really focuses and pursues innovation. It drives innovation. The manufacturer knows that they're going to be evaluated on the system. And they also have found a way to make sure that patients still have immediate access to drugs. That 12 months, first 12 months in the market, while all of the rest of the evaluation is swirling in the background, it helps make sure that people have access to innovative therapies when they first come on the market. It also has a really kind of admirable emphasis on clinical evidence. You really are comparing these drugs against existing therapies. You are allowing for negotiation, and the manufacturers do play a heavy role in all of the parts of the process. They are able to weigh in, for example, even on the comparative drug that's used at the beginning of the evaluation. So they do maintain a heavy role within the process. And probably the other thing worth mentioning is that the drugs that have been removed by the market, it's not necessarily processed so much as the fact that they probably were not particularly innovative or beneficial drugs in the first place. If you come on the market with a drug that's incredibly innovative, you really can kind of swagger into the room and know that you're going to walk out with a pretty strong negotiating position. So the ones that have been removed probably speak more to the product than the actual process. Thank you.
Thank you.
What do you do? I don't get it.
need for the health care.
No, this is not up. Again, it's not there. Okay, great, thanks a lot, appreciate it. So, excuse me. That's what I did. My theme is really going to be focusing on competition. Competition really does work in the drug market. Competition works in all markets. I think that's something that we need to have a firm grip on. Let's see. Okay, I only have one slide, so I won't have to struggle with that again. It was interesting. Richard's slides, his early slides pointed out, but he didn't dwell on it, a major defect in the Part D program, which is the reinsurance part of the program. I just thought I'd explain that a little bit. And the fact is that Part D is not very well designed. Below the catastrophic threshold, which is about $5,100 this year, there is a fixed prospective subsidy paid by the government on behalf of each of the enrollees. It's fixed. So if it was purely prospective, then there would be huge incentives for the drug plans and therefore the manufacturers to try to keep their costs down. However, somebody had a great idea that, well, we've got to make sure we protect people once costs get too high, however that's defined. And so above that $5,100, it's basically a subsidy goes up with usage and with price. This provides a tremendous incentive to increase list prices. And of course, that also leaves room for rebates. So it really works out very well for everybody in the supply chain. It doesn't work out too well for beneficiaries, for taxpayers who are covering 80% of the cost. So if you want to get at the basic problem in Part D, you want to address that. If you don't change the incentives that are driving the prices, then saying it kind of misses the point. It also eliminates any hope for competition. Now, how do we know the competition works? Sovaldi was introduced in 2014, list price $84,000. Maveret introduced in 2017, list price of $26,000. These are not cheap. This is not cheap, but in the course of 3 years, having the list price, which is the only price we actually know anything about, drop by that much is pretty damn significant. And that's played out in other less dramatic cases. But the point is the competition does work. It works in all markets. It works in this market as well. So we have to open up competition. The other aspect of this, of course, is the balance between, and Len kind of alluded to this, but the balance between initiative and competition, innovation and competition. And there it's pretty obvious. People talk about this all the time. Nobody wants to address it. But we do have a situation where company additional market exclusivity by finding a new indication that a drug is used for. And some drugs essentially never go off patent. So we need to fix that too. This is a very hard thing to do. The Part D thing is actually not so hard to do except for politics. The patent issue is very difficult because it doesn't just affect the drug industry. It affects all industries. So somebody has to be thoughtful about what you do. But we need to work on those two issues. Otherwise, we're not going to have effective competition and we're going to have this problem. Okay, now what about binding arbitration? People, I think, popularly think that it has something to do with baseball. So, let's imagine, let's say Bryce Harper. And let's think Nationals. And so they try to have, I don't know whether they actually had arbitration.
He passed it up.
But it doesn't really matter. The fact is, though, that what we're talking about is a very simple situation. This is not a case where there are huge amounts of investment capital in very risky business. But whatever, it doesn't have any downstream effects that matter to anybody, except maybe another baseball player. But it doesn't matter to most people. Maybe season ticket holders have had to pay another $5, but it's not a big deal. When we're talking about drugs, we are talking about a much more complicated situation. So we have to accept about that later, but worry about what those details are. So the first question that I have is, who are you trying to help anyway? This is very confusing. On the one hand, you might be trying to reduce the, I'm going to stick with Part D because that's what Richard's talk was about. You might be trying to reduce the cost of Part D to the taxpayers. That's a good goal. I fully support that. But what does it have to do with the beneficiaries of the Part D plans? Well, not necessarily a whole lot, because there's an intervening factor here known as the formulary. You have to, in other words, you have to consider your policies. If you want to reduce, as I believe this is what's really driving Congress, they want to reduce the cost to beneficiaries. That's a different policy than reducing the cost to the program. They might be related, they might not be that related, but they are different. And so you have to decide, what is your policy goal? This is something that usually is sloughed over when we have these kind of discussions, but you really ought to think about that. There's another policy goal too, which is usually not a yes, we're going to do that. It's assumed that it's going to happen. But we also want to make sure, and this is that long downstream effect that I was referring to that doesn't apply to baseball. We want to make sure that we at least maintain access to the good drugs. I don't mean street drugs. And ideally, we'd like to maintain, keep incentives there so that we get more innovation in this space. I certainly am looking forward to that drug that's going to cure me of my many problems that are obvious to you right now. There are no such drugs at the moment. So balancing all this is extremely difficult. So then, one of my questions, what is the arbitration over? Is it just over the price today? Or is it over the price today and all price increases in the future for a specific drug? The design of the drug benefit. In other words, if you're also trying to do something for the beneficiary, but you're also going to try to control what the plans offer in terms of cost sharing and so on. This is a question that usually isn't addressed, but think about it. If you're going to think about this policy, you have to work through what is your policy, who you're trying to help. And all I'm saying is it's not just pick a price and go with it. There are many, not only downstream effects in terms of time, in terms of investment in pharmaceutical development, but also immediate effects of how whatever the savings are distributed among whoever it is you want to distribute them to, and how you're going to do that. So it raises the question of what are the, what's the future for Part D plans in this case? If you arbitrate over the expensive drugs in Part D, so what happens then? Does that mean that they're taken out of everybody's formulary and they are sold separately by the government or by some separate organization? Or are they inserted in the formularies, and then what position are they in the formularies? Are they put at the same level as the generic blood pressure medicine, or are they somewhere else? These are very difficult questions. And furthermore, if you start fooling with that, then you have to ask yourself, well, does this take away some of the bargaining power that the Part D plans have, which the Lens picture demonstrated Part D plans aren't too bad at working out a reasonable relationship between providing drugs and getting the prices or getting the costs to not rise too rapidly. Well, if you are you taking away the ability of party plans to do that other kind of negotiation that often hinges on less expensive drugs? It depends on the drug. Away, and you have to think about what is the effect. And then maybe since I'm running out of time here, maybe I'll just say a few quick other things, which about information. So, it strikes me that this is the recipe for falling into what a lot of people on the left side of the political spectrum complain about when they hear drug companies say things about how to justify the prices. So this is a process where you get to justify your price. Now, I find this an absurd concept. Apple doesn't justify its price. I don't find it justifiable, so I don't buy that $1,000 iPhone. But nobody asked anybody else to justify a price. You put it out there, and you either pay it or you don't. It's up to you. Admittedly, healthcare is different, but nonetheless, you're getting into a situation where it boils down to what information are people using. What is the basis for the government's first offer on a brand new drug, for example? Something that hasn't been out there yet. It's just been approved by the FDA. What is the basis for the government saying what it's worth? Well, we're not talking about a process that's going to move very quickly. We're not talking about a process that's going to be based on a lot of data. We're not talking about a process that's going to get it right very quickly. And so the question is, will the government be willing to have a process that essentially says you're only going to get your price if you wait? I used to work at CMS HITFA. When I was there, I would have said, sure, we can wait. But if I were working on the Hill, I'd probably say, what are you talking about? These are senior citizens. They need their drugs and we need their votes. So I think there are some major real problems here, technical problems and political problems that are going to get right in the way of this idea. Thanks.
Thank you, Joe. Let me just take on Joe for a second and say, sure, competition is what we would all like to see, but these are drugs we're talking about here that have no competition. They're monopoly situations. They're valuable drugs, but they are not competitive with any other drug. So how do we go about dealing with those? And let me just run down two more. The second point is, I don't think anyone is offering arbitration as a total solution here. I mean, we could redesign the benefit, we can do other things that need to be done to address some of the problems in the pharmaceutical market. So arbitration is not a total solution, but it does offer, it seems to me, one important advantage, which is it does promote innovation, and it does keep parties at the table, as Richard said, which is very important. And then finally, what do you base decisions on? Isn't comparative effectiveness inevitably the key standard that is employed by the in Boston or anyone else that's looking at how to value new compounds? Doesn't comparative effectiveness offer you actually the only evidence-based approach that can be valid by and recognized as valid by both parties? Do you want to respond quickly, John?
Well, it's impossible to respond quickly, but look, we have to take the long view on this. What you're talking about is, why can't we get a solution right now for everything, right away? And what I'm saying is that you need to think more in broader terms. So I would push very hard for these more structural reforms at the same time that you're thinking about, Len says it's not price controls. Okay, it's not price controls, but whatever it is you want to call you can work on that. I'm not saying that all sorts of details that nobody has figured out yet. But the reality is that if we moved away from excessive taxpayer payment for not just drugs, but for everything in the Medicare program, and thought a lot harder about how we design our benefit, we'd be in a much better position. The fact is that Medicare Advantage, I'm going to say could work, as I'm not as enthusiastic as I probably could be, but the idea of prospective payment, the idea of a capitated payment, those are fundamental economic principles which we not educational. Sorry.
I wanted to ask either Glenn or Richard, what do you think the proper criteria would be for an arbitrator to evaluate a proposed price? What evidence is crucial to make this system work?
Thanks. I think, an arbitrator would essentially look, I think on one extreme would look at what is a reasonable rate of return given what a class of drugs, let's say biologics, how long does it take to get them to market? How much does it cost? Some of the things that Len mentioned. What is the size of the market? How effective is it? Dick Payton's book. What is the effectiveness of the drug relative to what's on the market today, treating that disease? I think those are the types of criteria that you would expect to have. And to some extent, we do this stuff all the time, only we've delegated to PBMs that have relatively little bargaining power against monopoly, but they do it all the time. And so somehow it's not like mysterious that nobody's ever done anything like this before. It's like we do it all the time. It's just let's do it under certain circumstances. I completely agree with Joe that we ought to fix, as far as I'm concerned, the reinsurance benefit is low-hanging fruit, and we should have fixed it a long time ago.
Well, it's not that low-hanging here.
It's technically low-hanging.
Exactly.
It's juicy fruit, let's put it that way. I agree with that. So one thing I would add to what Richard said is that, look at the different countries' processes for approving drugs in the first place. We are so afraid of bringing cost to the equation. We don't require the full amount of information that England and some of the European require to be shown on clinical database, if you will, that was standardized across the world, where you could do this comparative clinical impact sooner in the process. Joe's right, you don't want to wait 5 years for this, but there's no reason you couldn't do much better than we do now. We just need to require more data to be made public. I would say, at the end of the day, it's going to be a judgment about clinical value. And clinical value is not just length of life extended, although that's certainly part of it. Clinical value is also side effects and ease of administration and likelihood of taking it and all those sorts of things. And I would say, dollars per quality is bandied around about. It's got its problems. It's not perfect. It certainly would need to be adjusted for individuals who are never going to be fully healthy, and therefore their dollar per quality is always going to be higher. So you got to think about that. But that doesn't mean it's a terrible idea. It doesn't mean it couldn't give you comparative impact, and that would be a natural place to start.
A quick comment on that. I generally agree with you, but data, I'm a fan of data, but it's really the analysis that matters. And the analysis is driven by assumptions. It's not generally driven by, absolutely everything. And so, again, there are trade-offs here, which I think Americans have a hard time understanding their trade-offs.
We're not going to get into what Americans understand, but I would say that I would certainly agree you might want to have a price for a while and pay attention to what the hell happened. There's a tremendous amount of evidence out there that in both directions we've been right and wrong about what things are.
I-
And the Germans, I think, are better.
So as you described, the German system is quite successful. And so the question is, have other countries followed that model? And is it applicable to other countries?
I kind of view Germany as kind of a middle ground, in the sense that you have the US that doesn't do a whole lot of anything, and then you have Germany where you're getting into the comparative effectiveness side, and then you have comparative effectiveness plus cost effectiveness and qualities that you see in the UK. So it's kind of a middle ground in terms of where they're willing to go and where other countries have perhaps gone further.
So if there are questions from those of you here, I don't think we can take questions from people online, but we can for those over here. If you raise your hand. Yes.
So this is a sort of weedy question.
I'm sorry, can you just stand up so we can hear you a little better?
Sorry. Yes, and I'm Polly Harvey for the so this is weedy, but I always wonder, so you have the binding arbitration, the price is set. Is there some issue about what happens next year? You don't want to do the arbitration every year, so is part of that like what the allowable increase over some period of years, or what?
Yeah, I think there's a variety of ways you could do it. You could sort of, in a lot of places outside of drugs, these are done in multi-year contracts. And so there's essentially a schedule that's negotiated. So it's not just one price, it's a price plus an escalator or something like that. So that would be one way. Another way is you could do it formulaically, the way we do other prices in Medicare. You know, there are a variety of ways you could do that. Yes, right here.
Hi, I'm Marianne Hamilton Lopez at Duke Margolis. The fact that we're here is obviously that there is interest in this as a model. Do you have a sense if whether there's movement from the administration on moving towards this as a proposal, or you know, I know that sometimes we don't always know, and there's some surprise when it does come out. If there is the movement, if it's going in a certain one way or another. And then as a follow-up, you know, have you gotten a lot of feedback from both the manufacturer and the payer communities about where they would see the benefit of this model, and kind of how they would want to come to the table to move it forward or not?
So a lot of people have lost a lot of money predicting what the Trump administration is going to do. So I'm not going to do that, but I'll just say, look at the IPI.
Yeah.
And I really did mean what I said. I mean everything I said. Some things a joke, but still real. That's tectonic plate stuff for a Republican administration to propose using a concrete reference price from other countries here in the Medicare program. I mean, that's big. So that says to me they are open to a lot of different ideas. You pair that with their rebate proposal, safe harbor rule in PRM, and basically they're kicking both sides of the chain here, the manufacturers and the DBM. So I think this is a very different administration in all kinds of ways, and those two proposals alone signal the deviation from what I will call Republican orthodoxy for the last 15 years. So I think everything's on the table now. Are they going to get behind this tomorrow? I don't know, but they definitely are breaking eggs and taking names and engendering conversations about tactics to lower prices, lower costs for beneficiaries, and they're always going to be mindful of the programs. Richard?
Yeah, I've got a lot on the binding arbitration. I've talked to the industry, I've talked to consumer groups, and you know, I think in general it makes the industry very nervous. But I think that having it focused on places where the market, you know, arguably is not working, I think helps a little bit. And but I think having sort of a lot of outside input, having it not be done centrally, also helps. And then part of the idea around that sort of definition of the playing field up front comes because of, concerns by the industry that you could imagine prices being driven down below what might be a reasonable rate of return. And when you look across other countries, including Germany, they always include a reasonable rate of return in whatever criteria they're using to set prices or negotiate prices.
I might just add, it's not just the administration here. MedPAC is actively looking at this. Senate Finance Committee, there were senators on both sides of the aisle who mentioned arbitration as an answer for drug pricing problems. So I do think this is going to be of great interest going forward. Yes, right here.
This is for me as Frank, but I mean, just looking at the list of, I'm curious about how many drugs you think this would really truly be practical for to have a binding arbitration system, given complexity, like the list of 10 drugs that you have in your PowerPoint. I don't see any insulin products in there, for instance. I understand your point that these 10 drugs constitute a significant chunk of the catastrophic phase spending, but it seems like to me, there's still a lot that you're missing in that way.
And I think I go back to John's earlier point, which is like this isn't going to fix everything. And what I think the point is that if you, I'm an economist, and so this is kind of comes from the church I go to, which is you start where the market is most obviously broken, and start working there. And that chart is only meant to illustrate that you can get pretty far with a relatively small number of drugs. Do I think 10 is the right number? No. But I think that you have to really think hard about what resources and what your bandwidth is for doing this. And so I'm guessing, certainly less than 50.
But I think it's probably important to think about in the spirit of Joe's comments about let's think down the implications of this are. If you put something like this in place, well, you would have to, I can only imagine in the statute, you have to specify some general categories that would trigger, but it wouldn't be absolute and guaranteed. So you would change the environment in which folks brought drugs to market. And if they want to avoid stuff, then there's a simple way to do that, and that is to keep prices closer to some form of a norm that's established. And, again, if the administration is willing to look at the EU as some kind of reference point, then that might have a tempering effect over time.
That's the baseball point where 80% of agreements are done without resorting to formal arbitration because arbitration is the incentive, right? So,
yeah, just doing studies of different union approaches, ones that use final offer versus not final. The differential was like 20, 25 percentage points in rates of settlement. And so, it really does push people to settlement. And so that's the attraction.
Question about how you enforce this in this country, not in Germany, is a good question. So, you don't have to sell it. Well, that's politically difficult and also, I think, medically difficult. But also, basically, what's it called? Giving the right to produce the drug to another company. Now, that sounds attractive to some people. But it doesn't easily hold, especially for biologics. I would argue that it doesn't hold for biologics, and that's, I'm not going to call it a problem because I think that's where the science is. I don't call that a problem, but how do you enforce this? It's not the threat of negotiating anything. That's not an enforcement tool. The enforcement tool is something else. And I think the enforcement tool inevitably is going to be some kind of restriction on access.
Yeah, I don't think it needs to be. And so I'd be nervous about that. I'm also nervous a little bit about the German approach, which is essentially giving the generic price, because I think that really has important incentive response. But you could imagine sort of a penalty schedule for non-participation, and you could make it meaningful enough so that people would pay attention. And and I think again, because if you define that band, it gives people confidence about how far things could fall, and I think that again brings people to the table.
I think our time has come, but let me just say two things. One, this is just the beginning ways to deal with an unsustainable situation with pharmaceutical prices. And again, this is not the total answer, but I do think it offers some advantages that we ought to really think through. Wonderful panel.